Hi, it's Tom here from Running Physio. I wanted to come and talk to you this evening because tomorrow I have a rare day off with my son, so I thought we'd go down Brighton Beach and enjoy fish and chips together on the beach there. So I thought, why not talk to you this evening instead and talk to you about part 2 of our Getting Unstuck series. Now, this series is to help you with issues that you might have treating athletes and treating runners, and it's really inspired by you, really. So if you've got issues that you find, problems perhaps that you encounter treating certain conditions or certain parts of the assessment, please let us know in the comments, because really this series is about helping you find solutions to these common problems. I'd like to say thank you to a couple of people who actually suggested that we talk about distal hamstring tendinopathies today. Not particularly common injury, fairly rare, but we had 2 different people, Johan and Rob, who both mentioned it in the comments and replies to last week's video. So I thought we could talk today about rare injuries that you might come across in clinic, ones that you might see maybe 1 or 2 a year, and how you can approach those, and in particular to focus then on distal hamstring tendinopathy, so semimembranosus tendinopathy, but also biceps femoris tendinopathy in this video. We've also got a link to our free webinar series where we talk about Achilles tendinopathy, lateral hip pain, and lower back pain in athletes. That's another area that we don't see a lot of research and things about, lower back pain in runners and athletes. So do check out those free webinars. So how are we going to actually approach a rare injury in clinic? One of those ones that we don't see very often. Well, I think the first step is we have to maybe accept that with some of these rare injuries that there aren't necessarily going to be established answers out there. When you've got something like Achilles tendinopathy, patellofemoral pain, you've had loads of research, lots of studies, you're going to find at least some relatively clear guidance on it. But I think when you're working with something that's a bit more rare, that's not really going to be the case. So I think we've got to accept that first of all. But then I do think it's worth doing some research in it yourself. Have a look around, look into things like PubMed, Google Scholar, see if you can find some studies that have been published on the pathology and treatment of these. Now, in preparation for today's video, I did that for distal hamstring tendinopathy. I found a grand total of 2 studies on distal hamstring tendinopathies because they're that rare. There's really nothing out there. So we're looking at one study looking at surgical solutions for biceps femoris tendon pain, and one really sort of small case study done on semimembranosus tendinopathy. So for some reasons there's just literally nothing out there to guide us. So I think we have to accept that. We have to perhaps team up with our colleagues, ask them if they've seen something similar. Perhaps chat on social media, ask us and see if we've come across something similar, because we're here to help you. But ultimately, I think with these rare conditions, if you've not seen them before, we kind of just have to treat what we find. So do your assessment, look at what things seem to aggravate their symptoms and work to modify those. Work with the easing factors that the patient's identified for you. Assess them and identify their deficits in terms of strength, in terms of control, in terms of flexibility, and look to address those within the limits of their symptoms. Address the patient's concerns and work towards their goals. And sometimes these things can be really effective even when you're not necessarily sure of what the right approach is for these rarer injuries. Because as we said, we might have to accept that maybe no one really knows for some of these conditions exactly how to approach them. So let's talk a little bit about distal hamstring tendinopathies then. Now, obviously, I'm familiar with proximal hamstring tendinopathy. It's something I see an awful lot of in clinic. I've done a fair bit of research in it myself, so I feel quite comfortable knowing the treatment approach for that and the concepts behind them. But with the distal hamstring tendinopathies, I might see 1 or 2 a year. They're really not as common. Now, we'll start by talking about semimembranosus tendinopathy. So this typically presents with pain around the posterior medial aspect of the knee. It's often, when you assess it clinically, you can recreate it on palpation of that semimembranosus tendon, which is quite a useful clinical tip, is more easily palpated when the knee's flexed to about 90 degrees. So often you want to get them in knee flexion to palpate that tendon to bring on their symptoms. And you're likely to get it too with resisted knee flexion in your testing, and sometimes at end of range knee flexion too, where we think there might be some impingement of the tendon against adjacent tissues. Now, in terms of pathology, there's not a great deal out there at all in the research. As I said, just one paper. But they think there might be some friction between the semimembranosus tendon and adjacent structures like the medial femoral condyle that's going to occur during repeated eccentric loading tasks. So we can kind of factor that into our history taking. What has the person been doing in terms of their training, which may place high demands on the hamstring muscle and its tendon. So typically in our running athletes, this will be hill running, and faster running. Uphill running in particular seems to challenge the hamstring as it helps drive us up the hill. So we'd be looking out for those in the history taking and in the aggravating factors, because they're often the parts of training we're going to need to modify, at least initially, to help things settle. In terms of causes, there may also be some biomechanical causes. There's this theory from the one paper I've read that perhaps valgus stress on the knee places more stress on the semimembranosus tendon, and overpronation, which you do have to put in those little speech marks these days because we're not really 100% sure what qualifies as overpronation. But again, you might factor that into your reasoning and your assessment. If they're telling you, for example, that loading maybe in single leg squat is uncomfortable, and you test them and you see there's a lot of hip adduction that's placing more tension perhaps through the medial aspect of the knee, and you try and change this, if it helps their symptoms, for me that adds weight to this idea that it might be something that you want to try and work on as part of your treatment. So part of this treating these conditions, it's around a little bit of educated trial and error, of testing something, identifying something that's painful, and seeing if you can modify that with changing perhaps that movement pattern. Also, you might look at their running gait to see if there's a lot of adduction occurring, lots of valgus stress on the knee during that running gait. And as we'll talk about when we come to biceps femoris tendinopathy, you might also look at movements that place more stress generally on the hamstring, such as overstriding, increased forward trunk lean, or anterior tilt of the pelvis. Now, with the treatment then, in terms of how we might address the semimembranosus tendinopathy, we're going to work with load management as our first port of call, bringing the training down to a manageable level that doesn't cause lasting increases in the symptoms, and that's quite important. We might need to think outside of sport too. Now, there is some suggestion in the little research out there that deep knee flexion movements may irritate semimembranosus tendinopathy. Bit of a mouthful that. So it might be that actually we want to try and limit deep knee flexion. So imagine you're working with someone who spends a lot of their time in kneeling positions, perhaps someone who lays flooring for a living, and they're in those deep end of range knee flexion all day. That might be something you want to modify. So you might try something like this. Getting them to put a folded over pillow just between, just on top of their legs when they're sitting back into this kneeling position, which can actually stop them going into those deeper knee flexion positions if they need to be in this position for a long time as part of their work. So it's a little bit around solution finding, problem finding, maybe first of all identifying the issues and then thinking through solutions to how you can adapt their movement in the short term to make things more comfortable. And sometimes even with these rarer conditions, if we don't know exactly the pathology or the treatment process, you can still problem solve and work through it quite successfully. Then going on with the treatment for semimembranosus tendinopathy, we do want to do some progressive loading to strengthen up that hamstring and hopefully stimulate the tendon, but you would work within comfortable ranges. Sometimes they can be irritated at end of range when you're working into knee extension, for example, so you may work out of that range initially. So it's going to be a progressive rehab, graded return to activity, particularly a gradual return to the aggravating factors that people identify for you, whether that's hill running, faster running, sustained deeper knee flexion, etc. And they do tend to get better, but they can, like most tendinopathies, take time. So a few thoughts about semimembranosus tendinopathy. There's a few differential diagnoses there, of course, around the medial knee. So it could be an MCL injury, could be medial changes in the medial knee joint, medial plica issues. So it's obviously, of course, take a good history and make sure you feel comfortable. It's not one of those other issues that's kind of masquerading as a tendon problem. With the tendon issue, you're going to expect more well-localized pain that you can reproduce over that semimembranosus tendon itself. Okay, so that's a little bit about what little we know about semimembranosus tendinopathy. Next up, I would think about biceps femoris tendinopathy. So this is going to be more of lateral knee pain. Posterior lateral knee pain. Again, you'd expect pain on palpation of that tendon and with resisted knee flexion, possibly with resisted knee flexion and external rotation too, depending on the patient. So look at that resisted knee extension. This is one where, in my experience, it tends to be more sore when loaded towards the outer range of hamstring load. So when the knee is straighter. And again, this is not based on any research because no one's really studied it, but it's just something I've seen in the case that I've seen that's influenced treatment and has led then to more successful outcomes when we've addressed that. In terms of pathology, very little known about it. All I was able to find looking at the surgical papers is that biceps femoris has extensive and complex distal attachments. So there's a lot going on around that tissue, and perhaps that's enough to cause some irritation of the tendon in that region if perhaps there's compression from other tissues, or simply that the tendon is exposed to large amounts of eccentric load during running. Now, there is some suggestion too from the little research out there that biceps femoris may be more active in ACL deficient knees. So think about their history. Are the hamstrings having to work harder to provide stability if they're ACL deficient? Could that be part of it? That would, of course, lead you to want to strengthen up through that hamstring and generally through the knee. And particularly, I would think for those that identify pain when the hamstring's loaded towards terminal knee extension, that needs to be managed within the early stages to reduce that irritation. So if we think about it with our runners, when are we going to load in terminal knee extension? Well, the time we're most likely to do it is at the end of swing phase, just prior to initial contact. And that's actually where hamstring load is thought to be highest during running. And you're more likely to go into those end of range positions if you're overstriding, because you'll often land out in front of your body on a fairly straight knee. So one of the key things I would look at in a biceps femoris distal tendinopathy, I would look at the side view during running, see if they're overstriding, and if they are, can you increase the step rate to shorten their stride length a bit? Then they're going to land in a slightly more flexed position at the knee and perhaps not be loading that tendon in that outer range position, which is more uncomfortable for them. And we've had some quite good results with people with this in clinic, upping their step rate to reduce the overstride and reduce the provocative loading there. Like we talked about with semimembranosus tendinopathy, again, increased trunk flexion or anterior pelvic tilt can increase the stress on the hamstrings too. So think about it, if you were going to do a stretch on the hamstring, those would be the movements you'd combine. The legs straight out in front of your body, leaning forward from the trunk, a bit of anterior pelvic tilt. So if you see that in somebody's running gait that has a tendinopathy of the hamstring, it's likely to increase the stress through the tendon. So that might be something we could address, perhaps by looking at cues like run taller, or getting them to focus their vision on the horizon to bring them a bit more upright and make them a little bit less flexed. Now, again, a lot of these things are going to come down to a test, treat, retest approach, especially with these rarer conditions. So get them running, get them perhaps telling you about the pain that they're getting, scoring their pain during that run. Try a cue and see what happens. Does it actually reduce their symptoms during that run? Does the cue itself change the movement in the way that you want to? So again, I think particularly with these rarer conditions, there needs to be a little bit of trial and error, some reasoning that underpins it, but the ability to actually test things out a little bit and see what works, because we don't have those established answers out there. We also want to be loading up those hamstrings to strengthen the muscle and the tendon, but we may need to avoid that end of range knee extension initially if it's very provocative. As anything, you're going to be guided by the patient and their symptoms. So I might look at doing perhaps prone hamstring curls isometrically, but out of that range initially. I might use single leg bridge work with the knee at 90 degrees, because again, you're not going to go into that range. That way you can be strengthening the hamstring's role to flex the knee and extend the hip, and perhaps being in an eccentric biased exercise, like a deadlift, but not a straight leg deadlift, making sure the knees are flexed so you're not loading that tendon in a stretched, uncomfortable position. And then you could gradually progress the load based on symptoms before working into that provocative range once it's more tolerable for them. And of course, doing a graded return to sport, particularly a graded return to those more provocative training sessions, your faster running, your sprinting, your hill sessions, potentially that are going to place more load on the hamstring. Okay, so a few thoughts there on distal hamstring tendinopathy with semimembranosus tendinopathy and biceps femoris tendinopathy, and thinking about these more rare conditions that we don't see too many of. Just to kind of recap what we've said there, I think we need to accept with these that no one knows exactly what to do with these when there's virtually no research out there. So it is okay to kind of seek advice from others, treat what you find, and reason through the process with the patient to try and find the right solutions. And if you'd like to find out more about running injuries, do of course check out our webinar series. But really with this Getting Unstuck series, it is about you and the issues you find in clinic. So please let us know in the comments, what can we help you with? What questions do you have about treating running injuries or about various parts of the assessment? Maybe there's parts of gait analysis you get a bit stumped with, or exercise prescription. Let me know in the comments, because I'll be looking to tackle these things over the next week or so when we come to the next video in this series. And so I'd like to thank everyone for listening again. Thank Johan and Rob again for their suggestion for today's video. And I look forward to speaking to you all next week and hopefully having more questions and things to help you with. Okay, thanks again for listening. Bye for now.